Okay, so Natalie, I think I'll begin. And ladies and gentlemen, welcome to the RobinMcLeod lectureship this year. We are indeed honored that Robin McLeod herself can join us today. So Robin, welcome. It's really wonderful to see you. My name is Jim Rutger. I'm the chair of the Department of Surgery. And we welcome today Professor Carla Pugh from Stanford University virtually. Carla, welcome. Just before Carla gets introduced more formally, I do wish to do a land acknowledgement. You can read along with me. So we wish to acknowledge this land on which the University of Toronto operates. For thousands of years, it has been the traditional land of the Huron-Wendat, the Seneca, and most recently the Mississaugas of Credit River. Today, this meeting place is still the home to many Indigenous people from across Turtle Island, and we are grateful to have the opportunity to work on this land. Our treaty obligations and commitment include learning about the history of these lands and territory and the structured dispossession that Indigenous nations have been subject to by Canada, and learning about justice, equity, structures of power, and to imagine and how to build social relations for a different world. We affirm our solidarity with the Indigenous peoples of this land struggling for their self-determination and sovereignty from settler colonialism. Okay, and just a few words about Robin McLeod, who's on the line with us. So Robin, from out west originally, University of Alberta for her MD, did her general surgery training at the University of Toronto, then became a fellow at the Cleveland Clinic Foundation, and then did something unique in its time, which was to study clinical epidemiology at McMaster University, and she was one of the first in our specialty of surgery to do this, and has really blazed a trail as a pioneer in this space. Staff surgeon at Toronto General Hospital, Mount Sinai, professor in the Department of Surgery. She's been helping me as vice chair of the Department of Surgery with quality and best practice. She's received Lister Prize, James the Fourth Society Fellowship, Charles Tatter Surgeon Scientist Mentoring Award. She's been a Board of Regents member of the American College of Surgeons, American Surgical Association chair, membership committee, but then now is past president, having served as president this last 2 years. And this was of the American Surgical Association. She's been president of a number of other organizations listed here. She has over 350 peer-reviewed publications and over 250 presentations, grant capture continuously and consecutively over 30 years. Here's a photograph of Robin receiving the Lavina Lickley Lifetime Achievement Award in the Department of Surgery, which I had the pleasure of giving to her. And this is just some of the fine work that demonstrates Robin's involvement in best practice in surgery and the guidelines that have been created through her involvement of numerous committee members, and the website that has listings of the newsletters and all of these guidelines there for the residents, fellows, and faculty to take full advantage of. I mentioned her being president of the American Surgical Association, the oldest association for surgery in the world. And this was a Zoom call that we had where we had a trial run of Robin's presidential address. This was this year in March of 2021. And this is actually Robin giving the American Surgical Association presidential address in April. So really delighted that we could have a lecture named and endowed after Robin's name, and just delighted that she could talk at that time on the greening of the OR and the sustainability of the operating room. So I'll now turn the podium over to Natalie Coburn, who will introduce Carla more formally. Natalie.
Great, thank you. Dr. Rutger. It is my pleasure to introduce Dr. Pugh. She is a phenomenal researcher, and we've just spent some time talking with her about her research. And I'll let the audience know that we'll have a roundtable afterwards. So the residents have a few cases and research to present. And if anyone wants to stay afterwards for the discussion, that'll be from 8:30 to 9:30. It should be on the same link. So Dr. Pugh is a professor of surgery at Stanford University, and she directs a technology-enabled clinical improvement center. So, I think we've all talked about sports analogies and how if you're at a baseball game and someone scores, automatically their percentage of batting changes, and all the technologies that athletes use. And you can go into a center and look at your golf swing, but you really can't go anywhere and look at how you throw a stitch. And so that's some of the things that she's been working on. She's an acute care surgeon at Stanford. She did her undergraduate training at UC Berkeley in neurobiology and then a medical degree at Howard University. After she did her surgical training at Howard University, and then she did a PhD in education at Stanford and has been on faculty there. She has numerous awards and multiple publications, but I'm going to highlight that she was honored by President Obama in 2011 with the Presidential Early Career Award for Scientists and Engineers. And she also has a TED Talk, which sounds really fascinating. So I'm going to turn the table over to her, and we're really pleased to have her this morning to talk about the integration of technology and surgeons and education and how this can improve patient outcomes. Thank you.
Well, good morning, everyone. Thank you so much. It is such a huge honor to be able to share some of my research at such a leader in the space of surgical education. I have been a huge fan of the work coming out of your department for so many years. And again, it's a huge honor to share some of my work. And to give a lecture in Dr. McLeod's name, given all of her accolades and just really a amazing example of surgical leadership. And so thank you, Dr. McLeod, for all that you've done in our profession of surgery, but also for women in surgery and being a role model and an example. So jumping right into it, yes, I mean, it's very interesting to note that wearable technology is definitely mainstream at this point in time. And within the athletic space, but even a more recent survey that was done looking at data-driven clinicians and clinical work, that over 70% of, and is, obviously it's a biased study if you're interested in the survey, but over 70% of practitioners who participated in a survey of over 1,000 physicians use some sort of wearable technology, whether it's tracking their steps or tracking their sleep. And in addition to that, have modified their behavior based on the feedback from this wearable technology. And that's exciting for me because I do see this as the future of our clinical practice in healthcare. The science of touch, haptics has provided a major framework for me to understand and look at the data that comes from wearable technology, and I'll explain some of this. But I have worked with two scientists who have been at the forefront of haptics in the engineering space, and it's just amazing to see the work that they've done, obviously outside of healthcare and surgery, that talk about what we do with our hands and the cognitive haptic interface. And that has really provided a framework for me to understand what we do with our hands and how that relates to how we're thinking. The pause just before you move, how long do you pause? When there's rapid movement. And so I'll talk about the data from this perspective, and it's really grounded in the science of touch. Over the years, we have used a wide variety of sensors in our laboratory, partnered with a number of engineers that have fabricated sensors for us, this 3D sensor, the biomimetic MIM sensor, which is modeled after the hair cell sensor on spiders. Just amazing opportunity in terms of this space. And more of these technologies are coming to play, and they're less expensive. Many of them have really, really great potential to be integrated into sterile gloves or into fabric of the gowns and things that we wear in the operating room. So this is one reason that I stay in this field because I've seen the progression even in my short time in terms of the ability of these technologies to be integrated. Just a note in terms of combining haptics with metrics. We all know that the surgical learning curve varies, and I do make a distinction between the learning curve to competency and the learning curve to mastery. Those are very different benchmarks. The technologies and the processes that we would use to get to competency or to mastery would be the same. And I'll start to show you why I really am excited about the data that we're capturing with this technology and how it applies in both space, whether you're talking competency or mastery. It's been said that a skillfully performed operation is about 75% decision-making and 25% dexterity. And what I would offer in this space is that there is a visual haptic loop. And interestingly enough, your visual aspect of the field and how you are changing that anatomy with every move you make, there is this visual haptic loop with every dissection, everything that you cut, every move. And that can be captured with motion tracking data, and I'll share some of that with you. The other thing that I think this blending of haptics and metrics together provides, I think it provides us a new language. We listen to people talk about how they do their operations. We record it, we watch video, and adding to that, in addition to watching video, having a visual pattern of what you just did in the operating room compared to someone else or compared to your last case. There's something to it, and I won't talk much more about it. I'll share some pictures. In the simulated environment, this is my quantified surgeon. Lots of technology here, an EEG sensor. I'll share a little bit of that data, synchronized with video capture from the surgeon's perspective, synchronized also with motion tracking. We usually put at least 3 sensors on the surgeon, one on their index finger, one on the thumb, and one on the wrist. And these are magnetic motion tracking sensors, so we don't lose data with supination or other hand movements. Audio has turned out to be extremely important. We've done research independently in all of these different areas, and it's just been exciting to see how a surgeon talks about what they're doing, especially when during an unexpected event in an operating room correlates with the outcome of the procedure. Independently, each of these data streams have been very forthcoming in terms of helping us to understand the surgical workflow and how we go back and forth between our physical actions and our cognitive assessment. What's even more exciting is to combine these data streams and see the power of this combination in terms of understanding and dissecting the surgical workflow. So I will share 2 videos with you of 2 plastic surgeons doing a microvascular anastomosis. One person is a fellow and the other person is a 20-year veteran in this space. I'll tell you up front what happens. Again, this is under the microscope. The fellow, when they're doing their knot tie, they actually pull the end suture tail extremely long out of the visual field and then has a very broad or large working volume as they're chasing around this extremely long suture tail. One note in this space is that we've learned over the years that novices tend to accept unfavorable circumstances. So it's not only that there may be more errors, but the bigger issue is that they accept inferior circumstances. We as surgeons, more experienced surgeons, make some of these mistakes many times, but then we correct it right away before we proceed. This person doesn't do the correction. They also have a tremor on top of it. So I'll share you the data after the video so that you can see the difference. And there you go. They're pulling that in suture tail out of the field, and then now they're managing this long suture. I'm going to start the video of the more experienced clinician. Notice the experienced clinician is actually moving slower. There's so many things happening. And this is the three-dimensional, well, you're seeing it in 2D, but it's a 3D diagram of their knot tying. So this is plotted in terms of the colors, in terms of percent completion. I will show you other graphs where the 3D motion graph is plotted in terms of velocity. And so I will ground you each time that I share that, but this one is percent completion. So the blue is in the very beginning, which this is the first movement in terms of doing that first knot tie with the suture tail. Here you can see the blue areas in the beginning. There was a lot more management and chasing around of that suture tail. The second suture or knot tie is the green area, and then yellow. This is obviously expanded in terms of the game so that you could see the difference, but think about trying to verbalize to a resident or fellow the opportunity cost of that suture tail. We have these conversations all the time. It's one thing to verbally say it and someone to hear you and listen, but to be able to see it and see the difference in the work effort and the load and potentially efficiency. That's the beauty in having this type of data, is it not used to replace feedback, but it actually allows feedback to have a greater impact. And the difference between the two of these is just a simple rule-based error. That's another thing. A lot of the things we're seeing with this data when we're capturing it and seeing the difference between someone who has reached a certain level of efficiency and expertise compared to a novice is a good proportion of what we're seeing are rule-based errors. And rule-based errors are things that can be corrected just by informing someone and showing them the opportunity cost. This is not something that requires 1,000 hours of experience or practicing to correct. So that's another pearl that we've learned. There is a difference between trying to learn the learning curve for something, your haptic expertise versus rules. So with that sort of introduction of this, I'll walk you through a few examples of how we've used this data to quantify technical skills, cognitive skills, and mastery. From a technical perspective, using this technology, and this is a close-up view, the sensor is really only about 1 centimeter here. The rest of this technology is wired. They did not build it for surgeons to use in the main OR. And in fact, there is not a wireless version of magnetic motion tracking, and we are working towards fabricating that with some researchers at Stanford. The example I used in a simulated environment is that of a ventral hernia. I apologize up front for the MIS surgeons in the room. This is a simulator that we built over 15 years ago, and how we repair the hernias have changed since then, but it still serves as an interesting example. This is a physical simulator or task trainer that's tabletop, made of fabric so that you can use all of the instruments that you normally use in the operating room except for cautery. It's a fairly sizable 10 by 10 centimeter hernia defect. And again, I apologize that we don't just put mesh over those defects anymore. This is a close-up view of a surgeon at a industry course who's using the simulator, and they have anchored the mesh, pulled the hernia contents out and anchored the mesh, and these are the anchoring sutures, transfascial sutures, and now they're tacking with the laparoscopic tacker. This is just an example of some of the data streams we collect with the, even in the sim environment with the surgeons and residents wearing video glasses from their point of view, audio, motion tracking, synchronized with the camera from the laparoscopic view, as well as a camera from the external view, and then the tried and true checklist. And many of these have are using checklists that have validity evidence and are being used in the operating room. So anytime we build a new simulation or scenario that we want to capture and assess with our wearable technology, we look for a checklist that's already been used in the literature and has some level of consensus. We also have the residents do a self-assessment at FPA as a final product analysis. The good thing about these simulations, the fabric-based ones, is the skin that we fabricate, it costs less than $5. And so every resident gets to have a new patient, and it's not reused. And you can turn it over and look at what the repair looked like. One of the early things we found with the motion tracking technology is you could discern depth perception or the learning curve to competency within depth perception. And so this is an example, again, a depiction of the abdominal wall, the hernia defect, and one of the first steps is pulling through the anchoring sutures to position the mesh. And this is an example. This is a second-year resident in one of our studies who's having a significant difficulty with depth perception here. They're trying to hand the suture to themselves or pick up one of the suture tails. And it's one thing to, again, try to verbalize to a resident why you may have taken over think if this was a real case in the operating room instead of a simulation. The takeover of a case, many times we explain that there's failure to progress or in a timely fashion. That's really hard for the residents to hear. Because, this is my chance. I thought I practiced. I really want to do this. And now, the attending is taking over the case. And many times it's because of, simple things that can be practiced in the simulation laboratory, but also the feedback. We don't really have feedback that they can either really see or visualize. The video data helps tremendously, but also complementing this with the motion data, really adds to this. What I will show you is the motion. This is a motion diagram. This one is plotted in terms of velocity, and the higher velocity is in green, lower velocity is in blue. This is graded by their final product score in terms of their mesh placement. And so this was someone who was a top performer who got a perfect score. I'll show you the difference between a top performer and a bottom performer, someone who was in the lower tier. But the area of the motion diagram where their hands were in the laparoscopic instruments is here. This is the Mayo stand, and this is the hernia site for the patient. I'll do the comparison here. You can already see the difference. This person spends a lot of time at the Mayo stand, going from the Mayo stand to the patient, instruments in their hand, and they're putting their instruments down. A lot more working volume here, more movement. The other thing is you see there's a whole nother area of activity with this person compared to the top performer. And it turns out that this person made their incision for one of their ports too large, and their port and their instrument kept coming out. So they had to pause the procedure, suture that port site smaller so that then they can proceed. But obviously that had a huge effect on their time. And this is the back and forth. When the port comes out, they're putting things back on the Mayo stand, going back again. And so it's one thing to tell a resident, that really, affected your performance in this procedure, but not knowing, a comparison of what that looks like. The darker areas here are when you're slowing down. And many times that happens when you're completely paused and gathering information, or you're doing a part of the procedure that really, really matters, and you're taking the time to do it carefully. And we call this idle time. I know that you all are familiar with all of the work that's been done in your department with slowing down and what that means for surgeons. We can capture this with the motion data. What we wanted to do was get a sense of the relationship between the motion metrics and the quality of the repair. And what we found is that specific motion metrics do have a significant correlation between the full motion pattern and the quality of the repair. And smoothness is a velocity metric in terms of how fast you're changing directions. In that laparoscopic procedure I just showed you, that person was less smooth. Their smoother velocity metric because they kept, that port kept coming out really quickly, and then they're putting things in the Mayo stand. And so it's an indication of kind of frantic movement, and that predicts your product score. Also longer path length, the same issues with depth perception. All of these weigh heavily on cognitive load. What we found in some of the other studies is that junior residents who are learning haptic dexterity at the same time that they're trying to memorize procedure steps of a multi-step complex procedure, that it does affect the final product because of cognitive load and forgetting steps or actually creating errors. Once we knew that the total motion pattern correlates with the final product score, we wanted to see if any of the earlier movements, and so what we did was look at just the motion of pulling up that first anchoring stitch. And it turns out that pulling up the very first suture, just the path length of your dominant hand and pulling up that suture and the amount of time that it took actually predicts the quality or predicts, whether you're going to finish the procedure or not, but also the quality of the repair. That first movement, by the time you pull up the second suture, all of the movements, both the path length if you're a dominant hand and whether you're assisting yourself, that's how we operationalize bimanual dexterity, predicts what your score will be or the quality of that repair. And so lots of what we've taken away from this is that there is a opportunity cost in terms of technical proficiency that does affect your final quality of your repair. And so getting to some level of competency in this space and measuring it and having that feedback from residents is extremely important. I'll just pass over this. I want to get to some of the questions. From a cognitive perspective, we actually did one of our studies, looked at perception and how do we do that? What we did was we gave surgeons material that you're familiar with in your everyday life, balloon, tissue paper, and foam. And we wanted to see if they changed what they did based on their perception of what it would take to put 3 sutures in these materials. What you notice here, this is one of our earlier studies. These are LED motion tracking sensors. We stopped using these because they do have line of sight issues. And when you supinate your hand and the data capture unit above can't see the sensor, you lose data. So we stopped using these, but the data that came out was still very telling. For all of there were 10 students, 10 residents, and 10 attendings. And for all of them, the operative time for attendings, just in terms of placing 3 sutures across all of those materials, was less, which is what we expected. When you group all of the students or residents together and you look at their approach just based on perception, they had more idle time with the tissue paper. And many of them, spent more time because they were concerned they would tear the tissue paper with the needle driver, or not the needle driver, the needle to the tissue. And So they spent more time being cautious and pausing to make sure, that they didn't tear the tissue paper. No difference between the foam and the balloon. What was interesting is where people paused. And interestingly enough, entering the tissue with the needle, the students had the highest idle time. They were more nervous in terms of that. Residents, in terms of the drive, me and my researchers took every little, ever think about operationalizing the steps of getting just one suture in, breaking it up into multiple steps here. Interestingly enough, for the attending, they were more idle and more careful when tying the knot. And this was prolene suture. We did it on purpose in terms of having a suture that has lots of memory and requires management. And you can put 3 sutures in tissue paper, but it turns out that the students, just in terms of understanding variability in tissue and tying and all of the forces, had some issues there, and they did tear the tissue paper. But it turned out this was a new metric for us. Looking at using motion tracking, most persons think about, the dexterity part and when you're moving, but it turns out when you're slowing down and when you're not moving is extremely important, and it correlates not only with skill level, but also task difficulty. Correlates with surgical planning, with decision making and information gathering. As you put that suture in, how is the tissue responding to you? And we do slow down in those moments when we're gathering visual feedback and information from the tissues that we're operating on. So that was some of the technical as well as cognitive. I'll now cover a little bit of mastery here. We're still looking at a number of metrics to understand this. I'll play this and then I'll explain to you what you're looking at here. This is a cardiothoracic surgeon who we've instrumented the surgeon as well as their assistant, and they have motion tracking. We picked one of the 3 motion tracking sensors to show, just to display. So the one here is their left hand, and you see there's a much smaller working volume. Left hand is mainly assisting and moving back and forth, grabbing the suture. The right hand is the one that's pulling the suture through, and you can see these big movements here. The small working volume here is when they're placing the suture in the atrial appendage. And if I plotted this in terms of velocity, this would be the slower movement area, and this would be the quick movement area. One thing you notice as you look at these loops when they're pulling the suture through, one of them, there's something different happening here. And that's when the suture gets caught around the atrial appendage, and the surgeon and the assistant, sort of have different movements as they rescue that suture. I'll play it again. There it is. So it just shows you that we're not really missing anything, but it does give you a sense of every little thing that happens in an operation as an opportunity to, and nobody wants to look at 4 hours of video, right? But if you look at the motion pattern, you can actually select a part of the motion that correlates with the video that you want to look at. And so this motion data does give us sort of a roadmap in terms of cherry picking what we want to see in the video. Interestingly enough, again, this is the right hand of a fellow versus a faculty member. There are patterns that show up, and this one, a background C, the darker, this one is velocity. So the darker areas here are when the surgeon is really slowing down and placing the suture in the atrial appendage at that exact point where they want it. And again, the more experienced surgeons slow down more than those who are still in training and getting towards that level of mastery. More experienced surgeons are have more bimanual dexterity. This person is using their left hand to really assist them, so their right hand is doing that fine motor precision placement of suturing, and the cognitive load is balanced with helping yourself and assisting yourself in getting that suture every single time where you want it. We did a similar scenario with the residents. I think I'll go through this really quickly. This was a robotic pilot that we did, and we purposely put people in a situation where they had this, we call this the bleeding pelvic tumor. We didn't tell the participants that, but it didn't matter what you did in terms of dissecting this tumor, you were going to get into torrential bleeding. And we wanted to understand what people would do when that happened. It turns out there were 2 strategies. When they got into torrential bleeding, some of them paused, were sort of panicking a little bit and then asked for a different tool and started suturing. Others clamped the vein and then asked for a different tool. And I think you can guess which ones had the least amount of blood loss. And the idle time, we did idle time capturing that in terms of them making their first decision. And obviously there, you know, it was a small study. There were residents in general surgery, OBGYN, and urology that had some experience on the robot. And then we had a fellow, someone that was more experienced. And, you know, their idle time was 5 seconds, much less bleeding than on average than the junior residents. And so thinking about not only how your technical proficiency and efficiency, but also your decision-making pairs into mastery, that's an example of 2 different scenarios, looking both at the motion as well as lack of motion and where that occurs and how long it takes, gives us some understanding of both the cognitive and technical aspects of mastery. Most times when I give these talks, everyone wants to know, you know, do doctors really want to be tested? And it's just interesting for our team over the past 20 years. It doesn't matter whether we're putting sensors on mannequins for physical exam or sensors on practitioners or both. In this instance, with the anesthesiologist, we had sensors inside the mannequin, we had sensors on the laryngoscope, and then these wired sensors on their hand. And they line up by the hundreds. They've been doing it for throughout my career. It's just been amazing to see the response to this data. Many of these persons here are anesthesiologists that participated the day before, and they come back just to watch and see. Some of them are videotaping the computer of their colleague to see their motions, how they do their procedure and what their motion pattern looks like compared to them. It's just been amazing to have this opportunity. We've had a new one just before COVID with the American College of Surgeons, where we had a 1,600 square foot booth. And I thought the anesthesiologists were much nicer and that they would line up. I told my colleagues I didn't think the surgeons would allow us to put all of this gear on them. I was wrong, and pleasantly surprised and happy that I was wrong. We got several hundred surgeons to line up and allow us to put wearable technology on them while they ran a portion of pig intestines looking for injuries. We didn't tell them where they were or what the configuration was. And this was the data collection that we did in that meeting. And not only did they show up and allow us to put wearables, but they tweeted they tweeted their experience, and we have some amazing data we're still analyzing. I'll end here in that the goal is really to integrate this. My big dream, and I'm in this for the long haul. I know it's going to take a while, but to have this as part of what we do on a regular basis. I think we have work to do in terms of our culture, measurement culture in healthcare. Everyone wants to rank the surgeons, and my goal and dream is to use this so that we can do information exchange amongst ourselves and have this as self-regulated data. Obviously, there's legal things we need to do in terms of protecting this data from discovery, but the goal is really information exchange, both for those who are in training and reaching competency and some level of mastery, and those who are in practice and looking to master. Again, it's really exciting to see there's a wide variety of sensors being developed, pretty inexpensive, and have huge potential to move this forward. I've already begun wearing the EEG sensor in the operating room, and it's very interesting that the darker red areas are when I'm instructing a resident, but it also correlates with anatomical dissection or critical a move when you're stapling off something, and a different pattern for an appendectomy versus a cholecystectomy. And again, this EEG will line up with a portion of the video where something important is happening. So thank you all very much, and I look forward to your questions.
Thank you so much. I'm sure we have lots of questions. You can either put those into the chat or unmute yourself and ask the questions.
Yeah, so Carla, thanks very much, and amazing work that you've presented to us today, and congratulations over a series of years where you examined how the residents and faculty have performed. Question is these wearable technologies you mentioned, but also about the models that you use. Most of them were kind of physical virtual models, but what about like virtual reality models with haptics? Are we getting close to designing some of those? And I'm sure it's really complicated where you don't have a physical model to use to, test haptic feedback. But are there some good examples for surgery out there on sort of virtual reality models? So wearing goggles, seeing a surgical scene, having instruments in your hand, looking down on an operative field, but it's all kind of imagined, and yet having haptics happening at the same time.
Yeah, thanks for that question. I have been following the virtual reality space. We've developed a few VR scenarios in our lab as well. That is the issue. The haptics are not there. Not to train a surgeon to mastery or even to competency, because at some point you actually, the weight of the tool, how you use it. But I think that you could do, the VR glasses and the visuals have advanced much further than the haptics in the VR space. And so you can do depth perception, and you can have suspension of disbelief of the visuals with the goggles. I mean, they've really advanced with the headsets, Oculus, and many of them. But I think because the haptics are not there, there is a delay. So it's interesting. I spend a lot of time getting questions to partner with the folks in the VR world, and I sit on a few boards and research opportunities. And I think the best use of some of the VR is really for data visualization. So think about right now, I gave a whole lecture in 2D and showed you 3D data in a 2D manner, but to really see that in 3D and rotate what you're doing and have that in video, I think there's a huge opportunity there. So it's been funny. I've spent maybe the past 5 years heavily pushing folks in the VR community and telling them they're in the wrong business, trying to train surgeons with their technology, and they need to be in the data visualization. And they keep inviting me to speak because on one hand, they're in this space and they still believe that it's the right place, that they're going to train surgeons, total immersion VR. We want the Star Trek holodeck. But they do realize that there's more opportunities than just doing the operative field and trying to, teach surgeons how to operate with those visuals. So still a very promising space. A lot of people are very, very interested in, VCs are putting a whole lot of money in this space, but more work to be done. I think just our haptic visual loop of surgeons, we're so experienced in once your instrument passes through the liver, you're done. You're like, okay, I can't further maintain this suspension of disbelief and proceed. Helpful for residents and medical students to learn names of instruments, operative steps, some depth perception. So we've made some progress, but not quite ready for prime time.
Thank you.
There's lots of questions here. I don't know if you want me.
Yeah, there's lots of questions. I guess you will start with Dr. Darling's question. Are you using this to study your technology, or are you using it for training of the residents right now? Is it prime time, I guess is the question.
Thanks for that question. My short answer is my first goal is actually to build a performance database of experienced practitioners. Now, why would I do that? This is something that's supposed to be for residents and for teaching and training, because we don't have the metrics. Meaning, we train residents right now in a sim environment, and the experienced surgeons rate them using checklists with this vision of competency and mastery in our head. We need the data. And so if I had millions and billions of dollars, I would do both of them in tandem. But writing grants and doing this work, I get one shot. And so right now, my goal is to capture the database that then can be serve as the benchmark and criterion for the residents so that they have the metrics. But I feel like right now we're really giving, we're in the verbal feedback checklist mode in terms of our training, that the residents don't have the metrics of what we actually do as experienced practitioners. So that's my initial goal. We have done the comparisons. You see some of the comparison data, and obviously in that study with the ACS, when there weren't experienced surgeons lined up, we did allow the residents to come in. Of course, we want, the residents to benefit from this right away, but we need the metrics and the data analytics of the practicing clinicians such that then we can have a benchmark for the residents.
I think that speaks to Ralph George's question. He asked how this would fit into things like board exams or recertification. We have a number of people who are on the Royal College exam committees, and how far off would we be to integrating this into a Royal College exam?
So I could say my initial goal really is information exchange and more at the CME level. So what I've asked this question to the American Board of Surgery, and I've posted, and we're now even venturing on a video-based assessment task force. And in those conversations, the same, looking at surgeon performance, at what point are we going to get to credentialing regarding this? I think the first step is actually really giving people continuing education credits for participating. If you benchmark this as a credentialing process up front, before we even understand how to use the data, we're going to get pushback. And we need to serve the surgeons first. Our training programs, we don't have the feedback at the level that we want. Junior faculty, it shouldn't take a faculty person 10 to 15 years to perfect, a Whipple. But the reason it takes that long is because we do it based on verbal feedback, our own self-assessment, and morbidity, mortality metrics, which are outcome metrics and not process metrics. So I have to be honest, I'm pushing against the credentialing conversation with this data up front until we get more adoption and understanding of how we would use it. If I had to do it right away, again, you would get continuing education credits for participating. And then if you are found to be out of the range of competency, because that's the other thing, when we start talking credentialing, we are very fluid in our expectation or our conversation between competency and mastery. We want all of the surgeons to be gold medalists. And we cannot do credentialing at the gold medal level. That's not, if you think about credentialing, that is the whole goal of credentialing is minimum competency. Obviously, none of us want to be minimally competent, but if you're going to tell someone that they can't practice, you're going to not give board certification. It has to be at the minimum competency level, not the mastery level. There's a difference. We haven't even proven what level of competency you need. We don't have the process metrics to know what level of competency matches to a certain level of outcomes. We have no data. So I know that was a long answer to a very short question. How long is it going to take? Okay, 10 years before we're perfect at it. I think we're very close. I'm in the process of taking this to the point of care in the operating room next year, more fully, not just the EEG, but eye tracking as well as wearable. And that will allow us to embark on this conversation and have it up front and put those rules of engagement and order as we're getting the data, because we also have to protect ourselves, at least in the US, from our insurance companies. Some of them will partner with us, but others will try and stack the deck, right? We want all the Olympians in our place. So we have some policy work to do from that perspective. But definitely, a huge opportunity for remediation, for training, for a partnership, for information exchange amongst surgeons before we say whether you can practice or not, or what you need to become better.
That's a lot of opportunities. I think Emoji Hodai has a question. She has her hand up.
Thank you so much, Dr. Pugh. Fantastic talk. I wonder if you could address the concept of surgical insight and how this technology might allow either a learner or faculty to determine to what level a learner has insight into their own skills.
So what level that a learner has into their own skills?
Insight.
So it's sort of really a reflection tool. Mm-hmm. Oh, yeah. I mean, you definitely could use it for that. It's funny, we have looked at that a little bit in a self-rating of your confidence or your expectation in terms of your own knowledge of this procedure, your prediction. So we did do that with one of the studies. We asked them, for a specific procedure. It was with a lap ventral hernia about 15 years ago. And we asked them, what is your expectation for completing this procedure and having an excellent repair and a final product score. And as you know, it did pan out from a gender perspective with the junior residents that women tend to be less confident. But when we looked at the actual scores and the actual completion, there was no difference. So I think that this technology will help people understand where they are. It's really funny. When I first got to Stanford, I asked it was when Theodore Granchoff gave grand rounds and he was talking about some of the work that he's doing. And I asked the residents in the room, how many of you have gone into the room of one of your other colleagues to get a sense of within your year, how different they are in terms of what they do compared to you? And one of the residents said, we don't do any of that. We just assume we're all the best. We assume that we're the best. And so I thought that is so amazing. And I think I said, faculty walk around with knowledge in their head of how different you are in each of your years. We have that knowledge because we have to operate with you. But it's interesting that you all don't have that knowledge because you don't either have access to that information, we haven't given it to you, or our system of feedback doesn't focus on that purposefully. And peer evaluation is one of the most underrated tools. We're adult learners. My goodness, there's so much you can learn from your colleagues in your same year, let alone those who are more experienced. So there's huge opportunities there. And that's why, again, it's information exchange, sharing amongst your peers at your level, learning, and that fits into the workforce. You spend more time with them. Yeah, huge opportunities. Thanks so much for your question.
Yeah, I think Terry was going to unmute Dimitri because he had some questions. Oh, there he is. He's in. Okay, great. Dimitri, do you want to go next?
He's still muted.
Or Marissa, do you want to go?
Can you hear me now?
Oh, here we go. Yes, we hear you.
Hi, Carla.
Hello, friend. How are you?
I'm good. I'm not sure why you can't see me, but I had a question. Have you given any thought to using this technology and the various metrics that you've developed to study how a master surgeon's metrics may change as he or she ages?
Yes. So that project with the American College of Surgeons, the Surgical Metrics Project, that project came to fruition because of that question. we of the 250 surgeons that came, we had 20 of them that were retired. We want to have a longitudinal database. Everyone in that group was interested. I can tell you the short answer because we've done 2 studies now looking at retired surgeons and collected their, we turned them into quantified surgeons and collected their data. It turns out that they may have some motor slowing. So the haptic portion of what they do is slower, but their decisions are still on point. It's very, very interesting to see. And so many of the surgeons, we interviewed them, you know, they were all for it. They're like, wow, you know, for me, yes, the decision to retire or change the scope of your practice should be based on data, not a numerical age, because we saw surgeons that were 75 and they were amazing. And then we saw surgeons that were 65 and clearly there were some both motor and cognitive slowing or differences. And so they were all for it. You know, I had extensive interviews with some of the senior surgeons. They're like, you know, I would rather self-retire based on my understanding of my practice and my performance than to have at the end of my career a horrible outcome because of not knowing, you know, that my cognitive technical abilities affected my, you know, performance in a difficult case, you know. So there's definitely a lot of promise there, and that's a direction we want. A longitudinal database. You're ascent to competency, then to mastery, and then, you know,
The decline.
The decline. And what does it really look like? And where is the decline? Where does the decline take place?
Excellent. Thank you.
Thank you.
We'll take one last question from Dr. Loritas, and then we'll go into a more of a roundtable discussion with the residents if anyone wants to stay on the line.
Thank you so much, Dr. Pugh. That was amazing. My question is, you know, even from the simulated examples that you showed, suturing, tying one knot, there's so much data and so much interesting information that comes from a single task. When you plan to roll this out into the operating room next year, it sounds like you guys are very close, which is exciting. There will be so much data. Like, these operations are so complex and there's so many pieces to almost every step within even half an hour of maybe a 4-hour Whipple or a 6-hour case. How do you plan to manage all that?
Yeah, so I would use the laparoscopic ventral hernia procedure as an example. You know, look at the entire pattern of the whole operation. And when I showed the difference between those 2 persons, you can see right away, you know, that one person spending all that time going back and forth to the Mayo stand, and then this whole other part of the pattern that exists for someone that doesn't exist for another person. So it's high level pattern recognition. I don't think that, you know, looking at individual suturing and that type of, these are more, ironically, these are more looking at errors or detours in the procedure. That's what we've been looking at with the motion data. I think the place for, you know, dissecting, suturing and things like that is, if you are needing that type of feedback and training, is in the sim lab. The OR, I think you're really looking at workflow, you're looking at errors, you're looking at error rescue, you're looking at, you know, detours in the operation, and that's how you use that motion data to cherry pick what's important in the OR and how that affected, you know, OR time, blood loss. Was there a correlation? So high level patterns first, I think, but because you have the data set, if you wanted to do post-processing and take a deeper dive in any given case, you could do that.
Thank you. Thank you so much for the lecture. We wish you could have been here in person with us. I'm going to turn everything back over to Dr. Repka, who I think has some closing comments. And then anyone who wants to stay on the line, just stay on the line.
Yeah, so hopefully you can hear me. So just my opportunity to thank you, Natalie, for organizing this lecture, the final lecture of our calendar year, the RobinMcLeod lecture, and special thanks to Carla Pugh, who presented outstanding work, very timely for all of us to see how we can improve our skills and teach them to our trainees. And an opportunity for me just to say to all of you, have a happy holiday season. We're still living in this virtual world, but please remember to enjoy the time that we have set aside over the holiday season with your friends and family. Wishing all of you the best and looking forward to seeing all of you in the new year. So I'll turn it back over to Natalie. She'll keep the residents on board, and there'll be another Q&A session. But thanks everybody for joining today. Okay, bye-bye. See you.
Bye-bye. Thank you. Thanks so much.
Okay, I think Terry is going to try to move. Yeah, he's going to move everyone over to us. I'm going to hand things over to Julia. Julia is one of our research residents. She's doing trauma and acute care research. It looks like the residents are going to start pouring into this main room. They were all as observers without the ability to speak, unfortunately, for the last little bit. So Julia, I'll hand this over to you and take it away.
Great. Thank you so much, Dr. Coburn, and thank you, Dr. Pugh. This was really a great talk. So I was hoping for this session to be, an opportunity for residents to ask you about your work, to pick your brain a little bit, maybe also ask you about your career path. And I was hoping to also give an overview of some of the initiatives and work in surgical education that we do at U of T, and I'm speaking on behalf of a lot of different people. So as people trickle in, maybe if that's okay with you, Dr. Coburn, I can just quickly go over this. It'll be 5 minutes, and then we can launch into the Q&A.
That sounds fantastic. Thank you.
So I should have screen sharing abilities, right?
Yep.
Okay, great. Can you all see my screen?
Yep. Yeah.
So, this is a bit of an overview to give you a sense of some of the things that have been done at U of T. And I want to be clear that although I'm the one presenting, there are many people here that get the credit for these initiatives. Some of them I'm involved in as well. But I want to be clear about that. So I wanted to are my slides moving forward? Yes, they are. So there's a number of different things that we do at U of T and that are inspired by the likes of you and others. And as you know, surgical education is quite a broad field with many different applications. But hearing your talk and the discussion regarding the data and the lack of data regarding level competency and how to match this, and this relates to some of the work that Juven, one of our residents in general surgery, has done. And he's looked at leadership development programs, specifically for surgical residents. And this is a recent literature review that he's done, where he sought to describe and evaluate effectiveness of leadership interventions. And really what he's found is a little bit similar to what you said, in that there's very little literature. They identified only 9 studies for surgical leadership. And most programs were really centered in the classroom and theoretical, and they had quite a low effectiveness in terms of implementing change. And this really led to similar conclusions that, there's quite a heterogeneity and a limited quality of studies, and there's a need for development of an optimal leadership course model, and for the development of a bit of a more grounded theory of pedagogy and learning, and that there was a need for more systems literacy for surgeons. And this led to the creation of a curriculum element for surgical residents. And this was built here, and the teaching was really based on leadership, and this was administered to all the residents that were across all specialties in first year that do our surgical foundations teaching. So we're talking plastics, general surgery, neurosurgery, everyone really. And the idea was to address this sort of hidden knowledge or this hidden curriculum with the tacit knowledge and the know-how. Really, how do you implement all the knowledge that you have? And this curriculum covered also the the parts of the LEADS framework about how do you conduct yourself, how do you make decisions, how do you deal with the pressure. Very briefly, the idea was to, rather than just didactic teaching and throwing information, was really to encourage students to be vulnerable and put themselves in situations and think of how they manage those stressful situations, that friction, what are their strengths, how do they negotiate different situations, to build those skills. And this was very well received for the first year, and now it's in its second year. So that's the first initiative. The next one is a bit of an inspiring story in the pandemic. And so, as you know, in the last 2 or 3 years, well, 2 years, it feels like 3, a lot of the in-person teaching and in-person collaborations were slowed down, and especially in Toronto, we were hit pretty hard. In Toronto, we do teach the FLS course, and Dr. Krenek and the Temerty Center are the leaders in this, and I happen to be one of the instructors. But really, all general surgery residents go through this FLS courses that's administered through SAGES. And during the pandemic, what they've been able to do is to secure laparoscopic simulation boxes for all of the first year residents. And that's about 15 residents plus 3 or 4 instructors. And residents went and picked up those boxes, as you can see here, and they had it for a whole month. And what this led us to be able to do is really to make the entire sessions virtual. So they would be at home with their coffee and connected, and we would also be at home teaching them. And you can see that there's a little Zoom window. But this really sort of transformed how we were able to administer the course, and it allowed the students to have access to the boxes 24/7 for a whole month, which for a first year surgical resident, getting your hands on those instruments, as you can see, is probably quite exciting. And we did get really good feedback on this course, so the plan is to continue doing it this way for the foreseeable future. So not quite as technologically advanced as your work, of course, but for us this was a nice improvement. And briefly, before I open the floor, I wanted to also talk about a bit of a story of interdisciplinary collaboration in teaching, and this goes beyond just surgery. But pre-pandemic, this started actually 4 years ago. A group of internal medicine residents decided to try and address gaps in, once again, this sort of know-how and this how do you conduct yourself as a clinician. And they decided to initiate a series called Decrypting Clerkship. And these 3 residents were able to recruit other residents as quote unquote content experts from all over. So residents from surgery, from internal medicine, from family medicine, and they were able to build this curriculum for medical students. This was designed for 3rd year clerks. And it was really, a series of lectures that was meant to initially be a little bit informal and a little bit us passing down our knowledge, but that's now been formally integrated into the curriculum of the Faculty of Medicine. And these are all 1-hour sessions. They're case-based and simulation-based. And the topics are really everything that you don't find in textbooks, and I know that you weren't the biggest fan of textbooks when you were going through your training, and I think we all we can relate to that, a lot of us. But it is really, what does a med student actually do in the OR? How do you approach a consult? How do you, deal with pagers on call? And these were quite successful, and they've actually formally been integrated into the curriculum of the Faculty of Medicine now. So this is just an overview, and as I mentioned, there's credits to many of my colleagues, and some of them are present here today. But we were hoping to just give you a sense of what we do. So with that, I'll stop sharing my screen, and I'll open up the floor to my colleagues. I have a few questions, but I'll wait for others.
Well, thanks for that, Julia. That's a excellent update and presentation. Wow. The first thing that came to my mind, we've in a number of venues, there are conversations, about the length of time that a residency should be, and if we're going to have sort of, competency-based progression through a residency, what do we do with those who, reach competency within some realm, and most of those conversations are all about the care of the patient, but it doesn't include leadership. And when we start to talk about what does it mean to be holistic in our view of residency training, then that's, the reality check that, for those residents who, are really efficient in reaching a level of competency in terms of patient care and cases in the operating room, I think it's a huge opportunity for them to then do more in-depth work from a leadership perspective. It's such a huge part of what we do as surgeons in terms of being a team player, in terms of being, an instructor, a facilitator of the environment, not only on the wards, but in the operating room. And so I think that's amazing, just in terms of your framework for that, and that you're focusing on that, and making that, a formal offering in the curriculum. I think that it's very forward thinking to do that. And that's something that we all need to pay more attention to. Thank you.
Thank you so much. So if you guys want, we can do a few questions. I see Richard, you have your hand up, and then we also have Julian who can present his work. But Richard, please go ahead. That way people have time also to maybe grab coffee or.
Okay, sure. Thank you so much, Dr. Pugh, for spending this time with us and sharing your really cool work. I'm one of the residents, and I was wondering if there's anything that you think we can do to become faster learners as residents. We know that different learners have different shaped learning curves, and I look forward to when we can review our cases in a video or have data on our cases. But is there anything that you think learners can do now to speed up their learning?
Yeah, I think that's a really, really great question. And I've always, really have my heart out, for residents. And I still remember my residency year. You're so, so busy and you're pulled in so many different directions, and you're in a complex hospital system and running into systems issues, reading and learning. And when I think back, my short answer to your question related to efficiency of learning. And that, if you plant yourself in that framework and think about it, that actually requires you to do self-work in terms of learning who you are. What is your learning style? I could still picture myself when I was still sort of trying to force myself with textbooks when I really needed video. And sometimes people try to make themselves fit into what they think is normal, as opposed to really catering to their own self needs. I mean, it sounds, so basic and so, right. You'll know if you're a visual learner what you like, but sometimes I think that we spend some time self-criticizing ourselves or pushing ourselves to try and learn or be a way that we're not. And so I think that learning who you are, what you bring to the table, and spending maybe a little less time in the self-critical mode. I think when you are critical, what that does is actually help you understand how different you are and what you bring to the table. And it's worth spending more time understanding what that is. Where did it come from? And honor it and amplify it. And partner with your colleagues to have those conversations. And I'm going beyond just technical skills and interoperative decision making, but it's who you are when you take care of your patients, who you are in those moments when you have a difficult communication with a colleague or a consultant. Those kind of things actually take a lot of time. And so think about when you're having a bad day or you had that, how do you, what was your role in it? And how do you then get to a point where you recover from those incidents more quickly, or you prevent them in the first place because you know who you are? And I'll give you an example. This is all like sort of high theoretical. I'll give you an example. I am incredibly impatient when I think I know the answer. I have to be purposeful in listening and engaging in the process of communication with a colleague when I think they're wrong. And if you interrupt them, and if you are trying to, get your point across, like this is just an example, but it does, a lot of what we do as surgeons actually relates to relationships. And if you don't figure out how to honor them in an efficient and holistic manner, you'll spend a lot of time sort of fixing broken things that you broke, or yeah, I don't know how the right word for it, but fighting and arguing. I'll give an example. Some of our residents don't like the consult ticket. And so they go through this whole heuristic of, they're trying to dump this patient on us and this whole, and I'm like, okay, you guys are acting like you've already lost control, and changing your mindset and your workflow around that, your interaction with your colleagues and the interpersonal workflow gives you more time to study. So maybe no one's ever asked me that question before, so I don't have like the perfect, but it's part of it is time management. Some of it's self-management and self-learning. And I've helped residents win a lot of fights, whether it's with their colleagues or with themselves. And many times they don't know they're fighting for themselves. So there's something to it. There's something holistic in it. It's and that gives you more time, maybe more time to spend in the sim lab, maybe more time, go to the sim lab with your peers, with your colleagues. That gives you, when you conflict prevents creativity. We, in our workplace is a very complex environment, and so lots of opportunities for conflict. And so decide who you are in that space so that you can have more time for innovation, creativity, and faster learning. That part's free. All the other stuff, the technology and everything, yeah, coming soon at a theater near you. But the part you can do today is work in that space. Sorry if that's not the answer you're looking for.
No, that was helpful. Thank you so much. And yes, less time fighting emerge is also more time sleeping on call, which is maybe good for learning as well.
Yes.
Thanks.
That was an amazing bit of advice. I'm gonna steal that when the residents ask me that question now. I'm going to ask a question. Dr. Halle is there. I think her camera's not working. She's one of our faculty, and she started working on ergonomics. For the more mature surgeon. You guys are young, you don't get back pain after you do a long case, but are you integrating ergonomics into what you're studying, and how bad we are at predicting how much back pain we're going to have the next day based on where our head is, or how long we're holding back the liver or retracting for someone? How is that integrated?
Yeah, so we haven't in an experimental fashion purposefully integrated, the science of ergonomics into our work. But in some of our camera views, we're able to see it. And so in those moments, especially at the in the some of the laparoscopic where we have the external camera view, or in the anesthesia, you can see it right away, and it does line up. Some bad postures line up with certain things that you see in the motion diagram. We're not at a point where we have, automated feedback so that we could tell people. So we're still in the research mode. But obviously what you want is real-time feedback, and that definitely affects cognitive load, affects your own circulation, blood flow. I correct residents in the operating room all the time. I'm like, okay, right, we need to take a break. You're leaning in, your posture. And I tell them selfishly, I'm like, I'm looking out for all of my soldiers. And if you're doing something that is going to affect your ability to get to this operation with me, I need you to, need you to relax your muscles a little more so that you can operate longer. But yeah, the person who's actually doing more of the hardcore scientific work in ergonomic space that I know is Adrian Park. And he has different camera setup than I do. And so, but I would look up some of his work. Ironically, I don't know if it was his study, but he shared it with us that surgeons have less cervical and rotator cuff issues with robotic surgery than you do laparoscopic surgery. There's a lot of work out there in the ergonomic space. But Adrian Park is one of the persons I know, and there definitely been more than one study looking at the difference in sort of surgeon injury or back pain or things like that, comparing laparoscopic and robotic.
Delia, did you have another question?
Yeah, well, I have questions, but I can save them for the end. I think there's a question in the chat that came in first from Anissa Nazir. I can read it out. She says, "Hi, Dr. Pugh, amazing talk. Great to learn about surgical education activities." She's an MSc student at the Institute for Medical Science at U of T, and she works in Dr. Grant-Schroff's lab. And her question is, what do you think is the role of teaching, learning non-technical skills such as communication, teamwork, conflict resolution? Is that currently part of the curriculum?
So it's part of the curriculum. Wow, and now I'm trying to remember. So I'm not the program director or in charge of the curriculum for the residents at Stanford. But when I was more involved at Northwestern, we had a, wow, I'm trying to remember the name of it. There was an acronym, I think it was PAIN. And you guys may be more familiar with it than I am, but there was a standardized simulation-based curriculum with patient communication. And so we had standardized patients role play known sort of scenarios that require resident insight or trainee insight on how to navigate certain loopholes in a conversation with patients. I haven't seen one with conversations with our own colleagues, with consults. But I do know that I believe it was PAIN. The more and more I see it now, I'm starting to see all the papers come through my head because I took a deep dive in those about 10 years ago, and it was really exciting to see the work done in that space. But that's the only one that I know that at least has been developed by consensus. There were many years when the research was being presented at the Association for Surgical Education meeting regarding, but it was still focused on patient communication.
I see. Seems like there's so much to explore, really, and seems like you've done it all.
Or I've read or partnered with colleagues, and Yeah, you can't do it all, actually. That's why VR is one of those spaces where I go to the meeting. There was one called Medicine Meets Virtual Reality. I went to that meeting for 20 years, and then it sort of ended because it split off into so many different areas. But I keep close colleagues who do work in other different areas, because having a holistic view and understanding helps your thought process when you're designing studies and thinking about what outcomes are important and what you'll look at.
Yeah, absolutely. I can only imagine what comes out of those collaborations. So if, Dr. Coburn,
I have another question. So I wrote down one of the things that you said during your talk. So this is for the residents. You said novices tend to accept unfavorable circumstances more than experienced surgeons. So what advice do you give to your residents and our residents for how to accept those unfavorable circumstances? So I'll tell you, so we were in clinic all day, and then we rounded, and then there was a take back. And at the end of the case, the resident, and this is like 11 o'clock at night, at the end of the case, at 11 o'clock at night, the resident goes, "I have not eaten all day." And I did not know the resident had not eaten all day. And as a staff, I would not accept that unfavorable circumstance. I would have said, okay, you know what, between rounds and clinic, or rounds and the take back, or at some point I'm going to eat. But you know, with the long tail, where they're much more likely to accept a long tail than try to deal with it, or they're much more likely to accept unfavorable circumstances because of the power differential. What do you advise your residents and your trainees to fix that? Because that does waste energy. She would have been much more effective probably at the end of clinic and on through the OR had she stopped for 5 seconds to eat. How do you advise them?
You know, and just when you're saying that and giving that example, I had the realization that, you know, we give residents feedback all the time, but we actually don't label the feedback that we give. So they don't take it as that you're tolerating, you know, unfavorable conditions, and it does have an effect. I think that's the issue, is that we give them feedback all the time, like, oh, you should eat. But, you know, we don't then follow it and say, you know, this is my workflow around eating, and this is how I know that it makes a difference. It affects your cognitive load, it affects your fatigue. And we don't usually have it. If you think about having that conversation with them and giving them the feedback grounded in a space, then that enables you to say more, and that enables them to understand more, and then internalize it. But I think that's really the issue. It's not that we don't notice it or comment on it, but we don't complete the information around the thing that we're talking about to make it clear that this is feedback that relates to favorable, unfavorable conditions, and these are the outcomes that you will unfortunately experience. So I think it's more of how, you know, we don't even have a formal language of framing it, but that actually is the issue. And we talk about their posture in the OR all the time, but following up the conversation to say, yeah, you know, you're just, you know, I think people are a little more aware of posture, but maybe not as much in terms of their own personal wellness and wellness within the workflow. And carry a protein bar in your pocket or something if you don't have time to go stack the deck, you know. Reminds me of the bag of apples that I had in my car, because when I was in residency, we used to make, the cafeteria had like, it wasn't open continuously. I think they've changed that since, but you know, 15 years ago, the hospital that I worked at, the cafeteria was open for a certain number of hours for breakfast, certain hours at lunch, and we would make rounds before it opened for breakfast, go to the OR, and then finish in the OR and afternoon rounds, and the cafeteria was closed. So the only way that I was going to get food is food in the pocket and a bag of apples in my car. that I could eat on the way, because you never had time to make breakfast, but you could, you know, have something in your front seat and eat while you're in your commute to work. So you figure out how to hack your life. And I think the more we use that type of language and have a platform, I mean, you have to think about it. We're a bunch of surgeons that were having a conversation about wellness. 10 years ago, that was never the case. There was never a platform to discuss it. And everybody had their own workflow. And now residents, you guys need to know that the surgeons who have the most energy have a wellness plan. They may not call it that, but it's because they manage all of their other needs in a very efficient manner. So there's something to it. It goes for leadership as well. Those who are the calm, well-trained persons who always seem to win a discussion or an argument or something. They practice. They all practice. I used to think that people were just naturally amazing. There's no such thing. Everyone has some sort of training, and it's up to you to ask them, how did you learn to do that? I remember the first time a CEO of a hospital went into his drawer and pulled out his reflection book and shared it with me. I was like, oh my God, are you kidding me? He's like, yeah, I do a whole lot of work. I call my colleagues and ask them how do they handle situations. I write them down. I'm constantly learning. This is someone who's a 30-year vet. And if I never asked a question, I would have never known. And I would just assume that he was born amazing and that, you know, those of us who are not have to do a lot of work, but nobody else does, you know. So
pretty good lesson that if you don't ask, you're never gonna know. I think Dr. Musgrave, I see your hand is up, and then maybe we can have Julian do his presentation. Go ahead, Dr. Musgrave.
Thank you. I'm going to just keep going on what Natalie said about the accepting the unfavorable outcomes. Do you think it's because at that level of training, they don't have enough insight to know what is favorable and unfavorable unless it's grossly obvious? Or is it because they've never been given the feedback in a timely manner about that part of the operation to let them know that that's not a favorable outcome? So I wonder how much of it is our lack of educators and teachers in the operating room to talk about what I would call are the less critical parts of the operation. So for instance, let's put it in the general surgery frame, since most people here, that's their homeland. Bowel anastomosis. A lot of attention would be paid to the time around the anastomotic procedure, but maybe not as much time is going to be paid on closing the abdomen. So is it, I'm just trying to wrap my head around it as a teacher being in the operating room and giving people feedback. There's some times that I think that what the resident's doing is okay, like it's acceptable, but it's not the best. And as you said, it's the end of a long day. Everybody's tired. No one's eaten. The anesthetist's getting grumpy. Whatever it is, we're not giving them feedback on those small bits of the procedure that would lead them to understand that spectrum of acceptable and non-acceptable.
yeah, I think it's both. I think that, you know, when you're in the early part of the learning curve, there is this part that you don't know what you don't know, and so not understanding the consequences of what you're doing, and even when you have them, you think it's normal that now you have this, you know, all these other things to do in terms of your workflow because of the decision that you made earlier. And some people are so confident they would think, yes, I'm doing a great job, and the whole time they're talking themselves at a high level as they're, you know, having this incredibly, you know, inefficient and complex workflow. If there's someone who is extremely confident, they'll think that that's normal, and so they're not open to self-criticism or looking at that and saying, "Wow, is there a better way?" I think yes, the feedback is not there. I think we're not tuned in, and just as you were saying what you're saying, I'm like, wow, we need that list, right? Just think if you had that list, a quick list, and I'm thinking of those tidbits in a little software that you could look up just before a case. These are the 3 things that residents tend to, accept, unfavorable conditions that they accept. And a lot of it's rule-based behavior again. And so just figuring out a way to capture it, list it, and then make it automatic in the feedback process. But I think that it's not a mainstream topic or way of communicating right now. And so that's why it continues to happen.
That's great. Thank you for those answers. So I'll invite Julian to share his screen. So Julian is a general surgery resident, currently in his 4th year, and he's also doing his master's in clinical epidemiology and healthcare research, and in the process of transferring to a PhD. And I will give you the floor, Julian.
Thanks, Julian. Thanks, Dr. Pugh. This is some work that I did very early on as a medical student. And I think it's very relevant because it's about learning curves in complex HPV surgery. And it's a different way of looking at learning curves from the way that you have. And I'd appreciate any insight into different ways of looking at the data, but it's really looking at learning curves from patient outcome perspective, not from a didactic or hand motion perspective. So we know from lots of observational data that laparoscopic liver surgery has benefits for patients, maybe less blood loss, faster recovery, and perhaps lower complications. And now we have 3 actual randomized controlled trials showing, in fact, that there are some benefits. There's some differences into what each of these randomized studies showed, but there's consistent signals in the way that blood loss occurs in laparoscopic liver surgery. But what I really wanted to focus on is this how experience was defined in each of these randomized studies. So in Oslo Comet, which is the biggest trial, it was specific to patients who were skilled in the technique. So they were the only surgeons who could perform the surgeries. And this other randomized study, all surgeries were performed by 2 experienced surgeons. And then in Orange 2, which was probably one of the smaller trials, they specified that surgeons, quote, early in their learning curve were assisted by an experienced HPV surgeon. But none of these studies really specified what, being skilled or being competent really meant. And that could explain part of why there were different findings in each of these randomized studies. So what we wanted to do is try to characterize what that learning curve looks like in laparoscopic liver surgery. And it's like the perfect setting to study learning curves because it's surgery that's quite complex. It's surgery that, is consistently performed in the same fashion. And it's surgery that a lot of, we can capture the actual beginning of the experience for most surgeons because it was only introduced like in the, early 2000s. And that's exactly what we try to do. So we looked at the experience of 5 different surgeons at a single center that started doing laparoscopic liver surgery since 2005. So we were able to capture the very first laparoscopic liver surgery that was done by each of these surgeons. And we looked at their experience up to 2016. And this was a single center in Ontario. And as you know, or may not know, HPV is, for the most part of this time, is regionalized. So a lot of these, most of these cases will go to this hospital, at least for that area of Ontario. And we looked at specifically 342 either hand-assisted or totally laparoscopic liver resections. And we, our exposure, our measure of learning was cumulative cases performed by surgeons. So, the first 15 cases, then the next 15 cases, the next 15 cases, and so on. And that was how we defined the cumulative cases. We put it into blocks. And we used the first 50 cases as the reference for our models. And I'll show what that looks like. And because, statistically, this has a lot of issues because of repeated measures. We had to use mixed effect models that account for correlation within surgeons. But it also allowed us to look at different factors that might explain changes in case selection throughout your learning curve. And that's one of the biggest criticisms of these papers is that, well, is it that your learning curve is it that you're going through a learning curve, or is it that you're just changing the patients that you see, and you're selecting easier cases as you go along, and that's why your outcomes look better. So we were able to, accommodate for that using multivariable analysis by adjusting for things like comorbidities, whether the patient was cirrhotic, whether they had preoperative chemotherapy, what the size of the resection was, etc. And this is the part that I'd love to hear more about your thoughts is we use two different specific measures of learning. So we used measures of technical proficiency and we used measures of patient outcomes. And both combine, and that's what I've learned from the learning curve literature, give a very holistic understanding of whether or not you truly are characterizing a learning curve. So for technical proficiency, we looked at things like operative time and conversion to open surgery. And for patient outcomes, we looked at complications, we looked at blot loss, and we looked at whether or not the patient had a prolonged admission to hospital. So we used 5 different outcomes sort of to make it very redundant and see whether or not you're seeing the same patterns all throughout, and I'll show what our results are. So these were our patients. So median age was 62 years. 43 patients were female. Charles comorbidity index was 6, so fairly sick patients. And these were the diagnosis for liver surgery. So most of it was colorectal liver mets. Some was HCC, and then there was either benign or other types of metastatic diseases. And what's interesting is that almost half of or actually over half of the resections that we looked at were major resections. And major resections is defined as like 3 segments or more. So these weren't small cases. And these are, our baseline characteristics. So I'll just emphasize here what I think is most important. So here, I'll just go back. Here I'm looking at all cases, and then I'm looking at all those cumulative blocks that I mentioned to you before. And then what I thought was interesting is that throughout that learning curve, the proportion of major cases did not go down. It actually went up. So it almost signals us to the fact that surgeons got more confident as they went through their learning curve to actually continue to perform bigger and bigger cases each time. And again, it's just to show that it's not that people are picking cases that are easier over time. That's actually not the case, because we can see that major resections actually went up over time. And this is, again, the same graph, just showing it graphically. So as I said, we looked at different measures of technical proficiency and patient outcomes. So this is operative time, and I plotted the odds ratio, median differences here. So the reference is the first 15 cases. These are 60 to 30 cases, 31 to 50, and then 50 cases. And we see that there's a trend. And then finally, after 50 cases, we see a much highly significant reduction in mean operative time, so much so that there was a 1.5-hour reduction after you had completed 50 cases compared to your first 15 cases. Then we looked at odds of conversion, which again is a measure of technical proficiency, and odds of a prolonged admission, which is one of those patient outcomes. And we see the same pattern. There's a signal that as you go on, as you have more cumulative cases, your odds of conversion and your odds of conversion get lower. And after you attain 50 cases, your odds of conversion are 55% lower. We saw the same with prolonged admission, and the odds of a prolonged admission after 50 cases were 73% lower. We didn't quite see the same benefit, or we didn't see the same pattern with blot loss or all-cause morbidity. But what we conclude, at least, is that we do see some improvement in technical proficiency and patient outcomes after 50 cases, and we don't see that the morbidity or complications are higher early in that learning curve experience. So it goes to show that it's very important. And I didn't talk about the experience of each of these surgeons, but there was a lot of operating together or proctoring or mentoring. There was a lot of that early in their learning curve experience, and that's probably what allowed them to have an experience without increased complications early in their learning curve. A lot of people have asked me this, is it just changes in patient selection throughout your learning curve? We try to control for that as much as possible in our multivariable models. But there's always a possibility that there's something we haven't quite measured. But I just want to emphasize, and as you sort of mentioned in your presentation, is there is, even though we saw improvement after 50 cases, whether that means that you've obtained mastery, you've obtained proficiency, or you've obtained competency, I don't know. I don't know that we can quite call it that. But it does emphasize that you can probably shift that learning curve with added things like simulation, proctoring, and training your support staff, like your nurses and your anesthetists, to help you in that experience. So that's about it.
Well, thank you. That's amazing work there. Yeah, I think it's extremely interesting, and there's so many ways to sort of look at this and think about it. But it does, show that your variable of operative time decreases, and it has to be beneficial for the patient. And I think that what you may have seen, I can just sort of think through it. You may have seen the difference between competency and mastery. And when you're now at that master surgeon level, that you're and the thought of mastering different steps of the operation that will have a significant effect on your OR time. We've looked at that as well, not mastery of the entire procedure, but maybe mastery in each, segment along the way, and what is the most efficient, effective way to perform each of the critical decision-making points in an operation. So there's an opportunity there to kind of look at some of the differences in terms of what people are doing. I think that, looking at your variables, which you asked me before related to technical proficiency and patient outcomes. Yeah, I mean, I think operative time, conversion to open. It was interesting. I thought blood loss would pan out in this one, but that's I think it's great that it didn't, because that means that actually may be one of the steps that the surgeons in your group are better than surgeons in another group at another hospital, because they use a different instrument or a different approach. And we are learning that there are sort of regional differences in surgeon preferences and how they do things. And we haven't published it yet, but even with that, small bowel, repair, it turns out that what we used to call sort of surgeons' idiosyncratic way of doing things, I like to use this instrument, I like to start here and go that way. We always thought that those were surgeon preferences and idiosyncratic ways. Well, it turns out that some of them do matter, and it does affect outcomes. It does affect efficiency. It does affect workflow, and so that.
And also, with that, I think one of the comments we've gotten is the nursing staff, like them feeling more comfortable with, troubleshooting your laparoscopic equipment, and none of this captures, the learning of the anesthetist dealing with like the high CO2 pressures, or the nurses with the equipment and troubleshooting. So, there's a lot more to be done. And with your blood loss, I mean, part of it, I think, is blood loss is extremely poorly recorded. This is all retrospective data, so there's a huge measurement error in that regard. But also, could it be that early in the experience, surgeons were more likely to convert when they got into bleeding, and that's why the blood loss didn't quite go up. And but yeah, we definitely hypothesized that blood loss would be one of those things that we would see improvement, and we didn't. So other explanations could be there. And one of the questions that,
again, you're doing it locally, like you didn't compare this to really rule out blood loss. I mean, again, that it would be doing the study somewhere else where they have blood loss, and then it's where, what part of the case does it happen. But I think that even without that what you're seeing is that there is a difference, and it also points to a major issue we haven't really looked at. I don't know, maybe there have been some studies, but time in the OR does negatively affect certain patients. And if you then have a large enough study where you're then able to stratify, patient comorbidities, I mean, certain patients, their physiology really sets them up to determine how well they're going to do postoperatively, and many of them definitely would benefit from a 2 versus a 4-hour operation. So time in the OR, I don't feel like we fully have understood the pure effect on patient outcomes with respect to patient physiology and patient selection. So there's something there that will help us really underscore the value of simulation or feedback, or being more efficient in helping surgeons to decrease their OR times and ascend along the curve to mastery much more quickly. So I think this was great.
Yeah, oh, that's great. Thank you for presenting, Julian, and thank you for your comments, Dr. Pugh. I'm keeping my eye on the time. I know that we have a hard stop at 9:30. But before we let you go, and thank you for spending so much time with us, I was wondering if you could speak a little bit about your career path and what it was like to be the first one to pursue a PhD in education. Did you face any pushback, and do you have any advice for residents who might want to take one of the roads less traveled?
I did have pushback, and it wasn't really pushback. It was sort of like, why on earth would you do that? We're all educators. Like, why would you go spend time with a bunch of high school teachers? Yeah, I did. It was lonely, to say the least. And I purposefully, had a mindset that most people won't understand it, but this is my passion. And I was lucky in that I had 2 surgeons who understood. And one of them gave me the most sage advice. He said, the irony is that it doesn't really matter what you do or what additional training or pathways you take in the first 15 years of your career after your residency. And I looked at him and I'm like, of course it matters. Like, why would you say that? And he says, you're still learning who you are, and any experience that you have during that time will contribute. You're trying to control the experience, but you're trying to control the experience, but you're controlling it based on variables of how other surgeons view the experience, or what's more traditional or what's not, or the external factors. He's like, but the majority of what you learn in any of those experiences is about who you are as a person and what your real passion is. So if you have a great experience, then you learn that that's right up your alley. If you have a horrible experience, then you're going to learn that that's not the place where you want to be, and it's still contributory from a holistic perspective. So he says, a lot of people don't understand why you want to go get the PhD, but if you try to fit in the standard box that they are giving you, the worst thing that's going to happen is when you become a senior surgeon and you're thinking, what if, or I wish I had. So realize that how we benchmark some of our experiences, and we tend to do it, what school should we go to, in this region, or what fellowship, what residency, and we spend a lot of time on the external variables. We talk a little more about the people and the experience. We don't talk about as much as the community, the neighborhood, and there's no way to benchmark that because there's no data, but that ends up shaping who you are and what the experience is. And so I thought I think about that moment when I had that conversation with him. And, I stuck with that mentor in terms of going back and touching base. And I just learned to accept that, other surgeons wouldn't understand why I was doing it, and it's okay. um, yeah, it's sort of, it's learning how to protect your passion and how to blend that into the formal structure of a surgical career. Same thing when I was finishing my final chief year, studying for the in-training exam. I didn't study for it. I was studying for the GRE. And because I had to take that test. And so it was just, it was a decision, and you're going to stand out, and it'll be different if you're doing something different, but you also have to, you still have to honor your first passion, which is surgery. So you need to finish your residency. You need to, do your specialty, but that doesn't mean that you can't add a layer on of something else that you're interested in doing so.
Absolutely. That's so inspiring to hear. Thank you for sharing that. So we're going to conclude, but I wanted to give the opportunity, Dr. McLeod, if she's still with us, or Dr. Coburn, to just share some concluding statements.
Oh, it looked like Dr. McLeod just ran off to answer her phone. Robin, maybe I'll hand this over to you if you have any closing statements, and I'll just thank Dr. Pugh again for spending the morning with us, and wish you could have come here and we could have gone out for a nice meal and done all the awesome things we do with visiting professors, but we owe you a meal next time we see you at the college.
Awesome. I look forward to it.
Whoops, Robin, you're muted still. No, it's still muted.
If Terry tech support is there, can we maybe get some...
Terry.
Yeah, I've sent her a request to unmute, so she has to click the button.
It's.
Oh, she's there. I think she's good now.
Yeah.
So I've enjoyed things a lot and learned lots from you, Chala. One of the things that I wanted to ask you is that particularly what you've showed us at first is that do you always plan to do it that way? Because I was thinking that, if for me as a colorectal surgeon, that if I were operating on, say, a Crohn's disease and also a cancer in the right part of the small bowel, those two are the same operations that we want to do or find out, but the Crohn problem would probably be much more difficult to do that. And so do you take that into all of the cases that you're doing, Chala, like the one that you showed us? Would you choose the best people to do it as you showed us?
Yeah, and so I think that's a great point, and I think that there are what you're describing there is, the tissues are going to be different than the adhesions, and yeah, those are two very different cases in terms of the actual tissues. What we do find though is that in terms of the motion pattern and the workflow, that it tends to be the same. It just becomes an exaggerated pattern because you're ending up spending more time or having more movement in one part of the pattern when you have adhesions. So the workflow, whether it's a laparoscopic right hemicolectomy, the motion pattern and the workflow is still pretty similar. It's just that there may be more slower velocity, for example, or higher concentration movements in that certain space. And so it depends on what we're looking in the data for. If we're looking to establish and understand a workflow, then we take all of the cases and the surgeons who perform. The benefit of having the same surgeon who's done both is that then you understand that you can then drill down into the different decisions or workarounds, that they may employ when they're experiencing difficulty with the tissues or the environment or, blood loss in that case. And so we're able to note some of those special moments or detours. But in the end, if you're then looking for something specific to a type of case, then yes, you have to stratify by case type. But upfront, because there's so, small number of cases and so little opportunities to do it. If one surgeon wants to, do the wearables across multiple procedures, then I'm definitely going to say yes, because we're so early, in the space and doing it. And it gets me a chance to do intra comparisons, in terms of that surgeon's decision making. And so, yeah, but there are, a lot of different ways to stratify based on what you're really looking for.
No, it's good. It's good what you had to show us, and can't say anything more further about it. I'm just very positive for you.
Thank you so much. And it's a huge honor to spend time with you and everyone here today. So I really, really appreciate it. And thank you, Natalie, for all your hard work in terms of really pulling this together. I know the things behind the scenes that take place in phone calls and partnering with admins and the whole 9 yards. So I really, really appreciate it. And the same for the residents, your presentations and the questions and the extra time. I appreciate it. Thank you.
Thank you so much.
Thank you.
Thank you, Julia. Thank you for pulling this together. And thank you for Victoria, who helped pull all of this off. And Terry, as always, who is always behind the scenes and making everything work for us. As well, I think Nancy's still on as well. So thank you. And everyone have a great day in the OR.
Thanks, everyone. Have a wonderful day. Bye.
Thanks.